So it gives me really great pleasure to introduce my mentor, Dr. Jupiter, for Grand Rounds. And I was thinking of how to start this. And what I was going to mention was Dr. Jupiter's daughter, Stacy Jupiter, received a MacArthur Award, which is a genius grant. Um, and it got me thinking, the apple doesn't fall far from the tree. And I started thinking about what is genius. And genius, in many ways, in its scope of influence, might be measured by how much we take that development for granted. So we think about airplanes and telephones, printing press, books. And these are things that are part of our everyday life, and we take them for granted. And some of the fundamental ideas are very simple but very brilliant in thinking that you take a magnet and you spin it and you get electricity. Or you have an airfoil and you run it at a certain speed and you can fly off the ground. But when we listen to Dr. Jupiter's lecture, maybe think about some of the things that we take for granted. You fix uh, these fractures in soft bone with fixed ankle devices. If you have an elbow that doesn't move well, you cut out the bone. You fix distal humerus fractures with plates and screws. And so Dr. Veris told me that Dr. Jupiter was the most influential surgeon, orthopedic surgeon in the world when I started doing his fellowship. So I'll
Good,
pass
thank you.
the microphone to him.
Thank you. You know, sometimes the apple falls from the tree because it gets old and a little used up. So it's not always the best analogy. Maybe you could drop the lights a little bit. They're over here. Okay. Well, let me tell you just a little bit about myself. We don't always get a feeling for people when we interact on a professional level. I was born in the Bronx and lived the early years a couple of blocks from Yankee Stadium. And you talk about influence. I'm still an inveterate Yankee fan. That's me at the Yankees fantasy camp about 10 years ago, playing baseball with the old timers. I was recruited to Brown University to play soccer. I had set the Long Island goal scoring record. And we had a phenomenal team. We never lost an Ivy League game. And I also ended up playing baseball for them, and I was second team All Ivy infielder. Then I graduated with a degree in highest honors in classics, and then went to Yale Medical School. And one of my first papers was my thesis, and I did it with Gus White, who ended up chief at Beth Israel. I went for a year to internship at University of Pennsylvania, and there were two reasons for that. The first was my wife was from there, and that was a good opportunity. But more importantly, and one thing I never really told her, is I had signed up to be a doctor with the American Indians for 2 years, and the internship offered somewhat of a rotating experience with pediatrics and OB and medicine. It gave me a good foundation because I subsequently became an Indian doctor and spent 2 years working there in general medicine, delivering babies, did a couple of research projects. And I want you to focus on the hair, because the hair has an influence in my career. I'll show you. The Indian name for me was Tumbleweed Head. So after that, I came back to finish the second year of general surgery here at Mass General. And believe it or not, at that time, Bullfinch building had open wards. We were taking care of patients in the Bullfinch. And it was a remarkable year. It was phenomenal collegiality, though we were on call almost every other night. I presented Santa Claus at the Grand Rounds. And I think it was a very stimulating time. And that's me again in the residency picture. and still have the hair. And then I came into the residency in orthopedics, and really some of the buildings were really old, and they were ready to be redone. And I think it's interesting because I was young, eager, active, and working in these plants. Now the buildings are phenomenal, the physical plants and all that, and I'm old and stiff, and so it's a big change. But there I am starting at Children's Hospital residency, and where the hair comes in is I had applied in 1971 to be an orthopedic resident in 1976, and it wasn't a formal application process then. You sort of came up and interviewed a few people, and they put my application aside, Xeroxed it ultimately multiple times. And with my name, background in sports, and that hair, I was accepted as a minority student. And I learned that once I came, the word went out, and there was a lot of murmurs about that. But I did a paper with Lyle McKaylee, and it really stimulated me to look into taking advantage of all the different rotations and try to do some clinical research along the way. The highlight of those who rotated through Mass General was Breakfast Every Morning with Henry Mankin, which was interesting because most people were so nervous that they didn't eat. I decided, I'm going to have breakfast, I don't care because he would look to people who were just about ready to bite into the banana and then ask them the question, But it was a very different time. We had a lot of responsibility, and we had a lot of hands-on teaching at the bedside, and continued to pursue the academic through all the rotations. What you're looking at on the bottom were the chairmen of the different hospitals in orthopedics. And it was actually a remarkable group of people that were leaders nationally, internationally. I also was influenced by Bill Harris up there, and I did my thesis with him. While it is not a very unusual problem now, at that time, 1978, 79, to put a total hip in where there was infection before was very, very unusual. And this was published very quickly after we submitted it. And there's our residency group, again with the hair. We treated distal humerus fractures during my residency, for the most part, with overhead traction and letting the bones heal together. Internal fixation was really not in vogue. And right before I finished my chief residency, I was really close to leaving. A woman came in on Saturday evening with a distal humerus fracture, and I put her up in traction, and it just fell apart. And I didn't think I could leave it like that, and so I told the anesthesiologist nurses Saturday night. They were not happy. And I went and was looking at the AO manual, and the anesthesiologist came over and he said, "What are you doing?" I said, I thought he was interested, I'm looking at the AO manual. He says, "You have to read before you do surgery?" I said, "Yeah, what's the matter?" He said, "I have a good mind to call your chief." I said, "Go ahead, Saturday night, give him a call." And I went in and I fixed it, and it came together. And I had already committed to go to Switzerland to be an AO fellow. I had gotten an ORIF grant, and that really stimulated me to do that as a project, to look at their experience. And I'll tell you, for all the residents, if you have an opportunity to go elsewhere for 2 to 3 months, take it. Whether you have your family or not, take it. It's a wonderful experience. We spent 3 months in different centers, 2 children, my wife with her mother's lynx coat, and we had a marvelous time. But also, I became familiar with some of the men who influenced the world in the treatment of fractures, not only learning a lot, but interfacing and becoming lifelong friends with these individuals. And I think the association with the AO was very important for me in my career. When I came back, I was able to organize the first AO residence course in the United States, and that's Martin Allgauer and Hans-Jörg Wyss, who was president of Synthes. And over the years, I've been able to interface and travel in all the continents, teaching and learning within the AO family, so to speak, and continue to do that. And I think it was a very worthwhile endeavor. But my other passion was hand surgery, and particularly microsurgery. And the place to go was Louisville, Kentucky, in this hand center. And there was a real trauma-oriented institution. And every night we were doing a trauma call and even fingertips put back on. And I think this was probably the experience of every fellow by the time they were ready to leave. You know, I've had it. But it was also a growth experience. So I returned to Mass General in 1981. And among other things, if you look closely, you'll see the puka beads that I was confident in wearing at this lofty institution. That I wore from the Indian. It was a gift from the American Indians. And I thought, well, why not? Let me try to pursue my interests. I was fortunate to be allowed to do that, but it sort of got me into a lot of avenues of interest. And let's start with trauma. And I learned quite quickly that trauma, fracture care, and traumatology were not quite the same. In fact, the definition of traumatology is the care of a fracture that may fall into the realm of orthopedic traumatology by its associated soft tissue injury or polytrauma. This is something that Ted Hansen in Seattle preached. And as an example, in 1983, this young woman was run over by an 18-wheel truck. And along with her femur fracture, she had avulsed her leg, which was pretty beat up. But the knee joint had enough stability that we took and created a free flap from her amputated foot and provided a coverage as well as a sensate flap that she could end up with a below-knee prosthesis, which was a huge advantage as opposed to an upper higher knee. And in fracture care, it's elective, where traumatology, the fracture is urgent. Fracture care is to preserve anatomy, but in these cases, in part, is to help the patient overcome the trauma. There's a woman that was sent up from Attleboro missing a good part of her distal femur. And in traction, she was stabilized, and then we did a double barrel fibula transfer. Those are long vein grafts, and fixed it and let her rehabilitate during the time of the hospitalization. And I did this with Neil Jones, who was my fellow then, and she ended up with a very functional leg and overcame the other injuries. Or this man came from Maine. His arm was caught in a lathe, and he was whipped around, and he had an obvious open humeral fracture, but it had torn off his fingers, and with a compartment syndrome as well. And we fixed the fracture and then decompressed the forearm, had a long vein graft, and took the two usable fingers and put them on. This is about a 24-hour procedure, and he had a functional hand. Or this young child who fell off from his grandfather's, was mowing the lawn, and a sitting mower, and he fell off and grandfather didn't realize he ran him over. That's his elbow, and he lost all his fingers. We were able to put back one finger and got some fixation and coverage early on, and then went back for more definitive care. And I've seen him 20 years later. He's graduated college, and he doesn't want anything further done, but he maintained a functional arm. And finally, this man who was mowing his lawn in Maine, and the lawnmower blade came off and severed his foot. And he came down with really a relatively well-defined lesion and felt that replantation was appropriate. And it ended up the front page in the Globe after a lot of putting them off, and only publish it when it's it's alive and things like that. Well, we've had a long-term follow-up with him. He hunts. He's never had another procedure done. That's if you can figure out which one is his leg that was replanted. He has a functional gait, sensate foot, and certainly a life-altering injury and life-altering salvage, I would say. The next area that seemed to be one that needed some interest and involvement was the elbow. And as you know, there's any number of fracture patterns and injury patterns and reconstructive problems with the elbow. But let me give you a perspective of what it was like when I was training and then started practice. A stiff elbow, ankylosis, was felt, and this is the Bible, Campbell's at the time, felt to be both intra and extra-articular. So a soft tissue release was rarely successful. And in these cases, they recommended either arthrodesis, that's fusion, or arthroplasty. That's 1980 when I was back and ready to go. Heterotopic bone around the elbow. It was thought that under the best of circumstances, limited prognosis is most that can be offered. What about non-union? By the time non-union is established, all motion occurs at the fracture site. The elbow is stiff, and treatment by graft will end up with an unsatisfactory result because the elbow will be stiff. Malunion is rarely amenable to correction. And so we started looking at fracture patterns. And we started at one point with Kozenek, who was a resident here, and Bartsenek was a Czech surgeon, looking at the history of these. And interestingly enough, there are bones in the Warren Museum, which is now in a box over at the medical school. And the deaner there was so excited when I went over there to see him. He said, people haven't asked for this in 20 years, but they have these fractures that were there, and it's phenomenal. And then we looked at, with these individuals, looking at different patterns, and it was very helpful for surgeons to be able to preoperatively understand the fractures. This type of fracture we described with in a young woman with actually in 3 planes, and was repaired, and she had a very functional result. Another interesting thing is that fractures in the front of the elbow were generally classified as capitellum fractures. And we saw this and said, they're not capitellum fractures. They're different, and then started to analyze, and now it's a well-accepted recognition that these are, they can go all the way across the distal humerus. The same with Monteja. I would often be presented cases at different centers, and the exact same lesion here, and very little understanding. This was really described in 1951 by a British surgeon, but there was very little description. And then, so we put together this series. These are actually, my daughter made these drawings. and the journals accepted it, but defined the different characteristics, and then looked at some of the problems when they weren't treated adequately. I think these were very effective observations for many people, and we fixed this failed treatment. Another interesting category of injuries was the bipolar. This was described in Argentina by a man named Odina. Where people would drive, they didn't have air conditioning, they would have their arm outside the window, and then a city bus would come, and the windows, the mirrors on the outside would hit the elbow and force the arm into the dashboard. And they would have a segmental injury and proximal and distal, like a proximal Montigia and a distal Galeazzi. And this is an example. This young woman was in a motorcycle accident. So she's got a proximal radial head, radial neck, a shaft fracture, a distal radius fracture, and a scaphoid capitate fracture as well. And the approach was to really try to stabilize everything. And we fixed that. We did not get a very good reduction of the distal radioulnar joint, but she ended up with a very good hand function and full elbow motion. And the other one that had been described in 1904, but then was nothing in the literature, was this injury where the end of the humerus implodes into the proximal forearm, and was called a transolecranon fracture. And this is in a 16-year-old boy in a prep school here, and all that black is hematoma. And then we put together a series of 13 patients, but the way to treat it is to distract the fracture and then fix it. And he ended up with a good fixation and a good motion. And you know what he's doing now? He's an orthopedic surgeon. They call him Lefty, though. No, just kidding. The other thing we looked at is surgical approaches along the way. And one of the approaches that sort of fell out of favor was the olecranon osteotomy, but doing it in a specifically oriented way, and Kingsley Chin was a resident here, and Larry Gulata, you can have very good results, and it does help in the exposure. The other thing was I saw a number of patients who had multiple humeral fractures and went on to non-union. And there's a subgroup of patients that were obese or even morbidly obese. And I figured out if I put the arm up like this and a lot of the soft tissue would fall away, I could approach it from the medial side and then do a vascularized graft. And so I went, and that's not her femur, that's her humerus. And we did it that way. And the medial approach then takes you right down to the vessels, and you can approach the humerus anteriorly and preserve the musculocutaneous nerve and even remove a prior plate on the lateral side by just putting in a screwdriver through percutaneous holes. And this worked very well, and this patient did very well. But it led us to compose a group of patients with Howard Rosen in New York and looking at some of the difficulties in treating these patients. I take you back to that distal humerus problem. And this was the group of patients that I followed up while I was a fellow in Basel, Switzerland. They didn't have PACS system in those days, so this was every case that was drawn out by one of the registrars. But it was so well documented that it became a very important article for the Swiss AO, because the editors of the Journal of Bone and Joint Surgery through the 70s and early 80s did not believe, the Swiss did not believe that operating on fractures was so predictable. And because this was so well documented, they accepted it, and in 1985 was published. It was a very important landmark for them because it went then more easily into the literature. And we followed that up with unicondylar fractures. Because of some of the difficulties, I talked about the possibility of not using fixed plate angles, but put plates on where they're needed, so-called triple plating. This is a woman who came into my office, walked in with this fracture about 6 years ago, and Tuesday, and I was able to get her into Waltham ambulatory care the next day. I have to say that the Waltham ambulatory surgery orthopedic has made our lives so much better. The quality of care and the enthusiasm to get things done is a remarkable experience, and certainly allowed me to keep working. I don't know if I could keep working, having to fight the OR every case. But this was a very low fracture, and that's her scan, and that we put the pieces together, but then again using this 3-plate technique, and she had a very reasonable functional result. We can tackle some of the problems. What about infected fractures? This is a doctor's wife from Philadelphia who came up, was terribly infected, but her joint was still there. And using the techniques of Ilizarov, we could try to bring the pieces together and then actually let her move in this frame. And she ended up with a healed fracture and an adequate functional result. Or this patient came up from Wilmington, North Carolina. She had been injured by a horse and had several surgeries, was missing a substantial amount of distal humerus. And we brought the joints together, 3 plates, and then the vascularized bone graft to cover the defect. And this is 23-year follow-up, not fully functional elbow, but a functional elbow. We saw some patients who were dislocated 6 months and found that if you could bring the patient joints back together and get them moving with a fixator, you really could get a good functional result. If you read the literature, these were the kind of cases that were seen in third world countries that people, hadn't had treatment for years and years, but they didn't have the advantages of fixators. And this is his elbow. We also looked at and realized that not all these radial head fractures and neck fractures healed, and they didn't necessarily have problems because of the fixation. They had problems because they lost their circulation. So started to recommend maybe if you have 3 or more fragments that maybe you should put a prosthesis in. I really don't believe that now, but it certainly influenced the way people view these fractures now. Non-unions, as I mentioned, in the past were thought to be not very amenable to treatment. Ackerman was a resident, and we looked up a series of non-unions, and ultimately it showed that if you fix the fracture but also release the joint, patients ended up with a very good function. And we also looked at, with the British colleagues, intra-articular non-unions as well. This patient, as you're looking right at the end of his humerus with this non-union. And I put together a 30-year experience. I had close to 100 of these cases, even those that just had a little joint, and produced a method of classification. This was a nurse who had this failed surgery and found that you could put it back together, and this is a 23-year follow-up with a good functional result. This unusual fracture where the elbow is totally flail, and it's very hard to even see the end of the humerus, but by bringing these together and creating a V shape to the end of the humerus and impacting it into what is left of the joint, you could get a good functional result and not go to a total elbow. Even intra-articular malunions. This is a young boy, came from Maine, and frankly, he couldn't flex because the joint was so malreduced. And I took him to the OR and realized that maybe I had to cut the joint here, but I wasn't sure that's the right thing to do, but I did it anyhow. And he turned out to have, that's the fixation, fixing, here's the screws, and he had an excellent functional result. But more importantly, and those of us and all of you who are going to go into practice, know that the simple letter from a patient thanking you is worth its weight in gold, you know. And this I got 30 years after his surgery from his father. It says, no limitation, diminution of range of motion or power. He has unhandicapped movement and lifestyle. We should ask you when your birthday is. You should be recognized and celebrated every year. Somebody likes me. Thank you for giving our son a non-handicapped left arm. He's a life-altering procedure. Sometimes we just get it right. Thank you. We also found that even adults, middle-aged, older patients who had trauma and had a very bad ulnar nerve, if we released the nerve as part of the reconstruction, they would regain some degree of motor function, and that was against the literature as well. Well, why not lower limbs and upper limbs? This fellow, Hardy Weber, influenced me when I was in Switzerland too. He really was a brilliant surgeon. He developed these classifications for non-unions, and over the course of a career, I've taken care of over 450 patients with either infected non-unions, aseptic non-unions, or malunions, both upper and lower extremity. And I had the pleasure and good graces to work with our plastic surgery colleagues, Jim May and Greg Gallico and Mike Uramchuk, in many of these cases. As early as 1992, we realized that there were different degrees of tibial infected non-unions, and to the idea that it may take longer for rehabilitation, and patients should be aware and surgeons should be aware. And we divided it into the different levels. And as an example of a tibial defect that you can make the fibula intact or comes intact, this fellow was sent from, actually started in the Caribbean with one of the cruise lines, and he got a winch wrapped around it and was sent to Miami, and there was a former resident there who sent him up to here. And that's how he came up. And he had really necrotic bone and massive soft tissue. And putting them initially in fixators, reconstructing the fibula to make it intact, and getting coverage with a flap. Did this with Mike Uramchuk, and then going back and bone grafting posteriorly between the fibula and tibia. We had both limbs in the normal length and alignment and healed. And he walked out of Mass General at the end. Or this patient who had lost most of his tibia, but again still had a usable fibula, did with Jim May, and here he is, 12 years follow-up, and if you can appreciate how much the fibula hypertrophies when it bears weight, and as well as the cancellous bone becomes cortical bone. The advantage of one-stage procedure, that's a vascularized bone graft, was apparent in many of these type cases. This fellow came in 1983 having had surgery on a hip fracture and femur fracture, and both were infected. And what you're looking at here is dead bone here and a dead femoral head. We don't have vacs in those days, so they had dressing changes on the floor until they had a healthy wound, and then we went and put a vascularized bone graft in. And this is at a year later. You can even see how both of these components are enlarging. And then Don Riley across town was brave enough to put a total hip back in. This is a 25-year follow-up. He's had no further surgery. He walks, and look at how the bone has grown. This is what's called Wolff's Law, where a bone responds to stress. So the living bone will respond to the size of the requirement. Or this patient who came from Saudi Arabia, he was in the military. He's obviously missing his elbow. And what we did is put him in a fixator and then let him adjust the fixator to define what position he felt most comfortable in, and then put a vascularized graft. And so he chose himself the position. Chris Chiodo, when he was a resident here, we looked at cases we did with these crazy femurs, malunions, and did osteotomies of those. And some osteotomies in the tibia were interesting. This was a woman who was a professional ice skater and instructor, and she had a malunion that really involved angular deformity, rotatory deformity, and the way it seemed at the time would be to just cut it, realign it with a distractor, put a wedge graft in there, and compress it. And she ended up functioning very well back to her career. How about this patient who similarly had a leg that was very hard to figure out? But we did the same thing, cut out a wedge below and put that wedge above and lined up his tibia. And he had a reasonably straight leg. And then I lengthened him once I learned about the Ilizarov technique. I did a lot of work with non-unions in the upper limb, including clavicle fractures. This is a long-standing clavicle fractures. And it became apparent that if you could distract and then put in a shaped graft, it added to the stability and healing, and then put a plate on it. So the graft is about 3 centimeters here. 1988, I led a group of orthopedic surgeons to China, and what I came away with there was microsurgery. I learned decision making, which was put it back on for everything, but also some of the tactics. And this was a young boy whose arm was caught in an industrial accident and machine, and we replanted it and hopefully regained some function. That he had his limb. Or a 12-year-old boy who also had an amputation and had a successful replantation and a functional hand. This fellow had not only an amputation across here, that's his x-ray, but his injury involved all the structures proximal to that. So we had to do a long vein graft to make a new vascular channels and then interpose his tendons. And he had decent sensibility to his hand and adequate function, but not far from normal. But a measurable grip strength. Whereas this fellow had a very clean amputation, if there could be such a thing. And once we got comfortable with the revascularization, we started to use more stable internal fixation to rehabilitate the patients more quickly. And so even while he was in the hospital, we started to move him, and he had a very good functional result. Over the years, I had enough of these to never want to see them anymore. A lot of night times and daytimes as well. And this fellow had a functional outcome and a aesthetic outcome as well. This young boy lost these 3 fingers, and when Neil Jones was a fellow, we came upon the idea of, instead of fixing each vessel, we would put vein grafts shaped like a Y and attach them to the 2 fingers and then bring them back onto the hand. It saved a lot of time, and added a very strong inflow of arterial revascularization. And he ended up, he won an award when he was senior in high school in his industrial arts class. The other thing about all of these patients that you don't dedicate so much time, effort, and energy is the interaction with the families and the long-term follow-up. And people are so anxious to let you know how things turned out. And it's really a worthwhile endeavor. 1990, I led this same organization to Russia, and I had time to spend with Ilizarov, the master, and they actually tried to sell me stuff and have me become an agent for them, not political agent, agent for selling. But the idea of Ilizarov allowed you to do a lot of creative things. In this case, I did also with Mike Yaramchuk. It's a girl from Greece who lost most of her forefoot and through the midfoot, and she had unstable skin and bone coming through, and we took that all off and put on a hemilatissimus flap, very bulky, because I then cut each metatarsal base and lengthened them. And I lengthened them till they were the length of the normal metatarsals. And then we trimmed the flap. So she ended up with a foot that wore a normal shoe and walked with a normal gait. So by combining these two technologies, this is a man who came from upper New Hampshire with this tibia that was obviously not alive, having had surgery, but he did have a joint. And what we did is remove all of this, put the Ilizarov on, and then transport the bone up from below all the way up and allow the bone to regrow, called a regenerate, and then had to fix the end point here. But he ended up with a little asymmetry of his soft tissues, but a very functional leg. He runs as well. It's also very useful in the foot and ankle. This is a fellow with a very bad pilon fracture, ended up with a quinovarus cavus foot. And you can correct all of this with the Ilizarov. Correct the foot deformity, the malunion and non-union of the tibia, and lengthen the bone as well. And he ended up with a plantigrade foot. This young boy from Haiti probably had a childhood infection, and most of his humerus was gone. So the Ilizarov allowed us to stretch the soft tissues and then put in a vascularized graft. This fellow said to me that's the first time he feels like a whole man as well. And I ended up with hand surgery, which is where I started. In 1980, in Switzerland, I met Diego Fernandez. We became lifelong friends, but also had a great interest in fractures of the distal radius. And when I came back, Jerry Knurk was a resident, and he needed something for a thesis, and I was collecting intra-articular fractures in young people. And Jerry put it together, and we had a nice paper, but it really had an enormous impact factor. This paper has been published. Knurk, I think, is a spine surgeon. But it allowed me to start developing with the AO the use of locking plate and locking devices and such. And these plates work very well on the volar side, considerably before the modern day plates. We also developed bone modeling. This is in the late 1980s, way before computers, but allowed us to model the fractures. And this is a general surgeon from New Hampshire who had this terrible fracture, but we fixed it in the model, and then we're able to go to the OR and get a much better correction. And the last case, probably the most intriguing, was a woman who had these bony growths only on one side of her body. Anytime she had a procedure done on one side of her body, she developed these massive bone growths. No one could figure it out. But she came here because her index finger was not functional and she had these massive growths. So Henry Mencken said, listen, take a flap from her other side and put it on there. And sure enough, the dissection was very difficult. Everything was encased in these bones. That's what we took off. But we put the flap on, and guess what? In a long-term follow-up, she's never had a regrowth of these bony masses under the flap from the other side of her body. I figured that out. It was some kind of weird disorder. Along the way, if you started in this system as an instructor, to get to be a professor was a long process. As long as you kept going, ultimately, you don't win by your brilliance, you don't win by your accomplishments, you just win by your persistence. And but here's a few things I learned that will not change even when you become a professor. Getting preferred OR time, having a larger office than your fellow, waiting in line in Coffee Central, having a white coat longer than those worn by a second-year student, or anyone ever calling you professor. I did have opportunity in national organizations to take a leadership role, not always willingly, but I did it anyhow, and that was very productive. And I think one of the hallmarks was this year I received from the International Hand Society a award as considered a pioneer of hand surgery. Along the way, I've been able to write and publish a number of books, and I made a lot of friends throughout the world. I continue to keep the friends, and along the way, enjoyed a lot of life. We have a second home. We're Coloradans, and probably will settle part of the year there at some point. And we've gone skiing a lot, raised our family on skis. Now I'm a grandfather, although they live in Fiji. And I think when your knees still work, Bert, if he's still here, you can do a lot. The Yankees, playing soccer in Shanghai, ice hockey, and that's riding a bicycle in Vietnam. So I end by saying much I've learned from my teachers, more from my colleagues, but most from my students. Thank you.